Good evening, dear professors and colleagues. It's my great honor today to participate in this great event. Thank you so much, dear Professor Maggie, for the organization. I would like to present our endocrine insights for the application of cystic fibrosis from the endocrine perspective. I think the first half of the day we covered the pathway of diagnosis and era of evolution of the diagnosis and treatment of cystic fibrosis till reaching the modulatory therapy. And this era of advancement changes the paradigm of innovation and technology and treatment of patients with cystic fibrosis, which implicated the improved survival and unmask the endocrine complications of these patients with cystic fibrosis. In the next 15 minutes, we will cover and hit briefly the endocrine complications we suffer and encountered with patients with cystic fibrosis, covering these parts regarding the growth failure, cystic fibrosis-related diabetes and delayed puberty, and sometimes rarely the adrenal insufficiency. As you see here, this is the reports of 2023 published from the Cystic Fibrosis Foundation, publishing the extrapulmonary complications of patients with cystic fibrosis. As you see here, the most important extrapulmonary complication encountered in this patient is cystic fibrosis-related diabetes and the bone disorders in different forms, the osteoporosis, the bone fractures. So we will start with cystic fibrosis-related diabetes. Cystic fibrosis-related diabetes is actually the most important extrapulmonary complication encountered in these patients, and it's a part of spectrum of progressive glucose tolerance abnormalities defined mainly by oral glucose tolerance tests. The onset of cystic fibrosis-related diabetes, it's very important to know this is the first time to detect this abnormality detected by the oral glucose tolerance, and this defining the time of diagnosis, it has a very great clinical implication to start the screening for micro and macrovascular complications of patients with cystic fibrosis-related diabetes. The pathogenesis of cystic fibrosis-related diabetes is very unique and complicated pathway, covering both parts regarding the insulin deficiency and the insulin resistance. As you know, that defective CFTR gene mutation leading to production of vicious secretion blocking the pancreatic ducts with subsequent inflammation and destruction of the exocrine part of pancreatic beta cells with subsequent fibrosis and destruction of the endocrine secreting cells, alpha and beta cells, leading to insulin deficiency. But at the same time, the chronic inflammation and infection and subsequent use of chronic steroid therapy leading to a state of insulin resistance, complicating the pathogenesis of cystic fibrosis-related diabetes. Usually, detection of fasting insulin and C-peptide being normal is not excluding at all for detection of cystic fibrosis-related diabetes, and most of the patients with cystic fibrosis have a defective insulin response to oral glucose tolerance test. Due to the critical importance of diagnosis and treatment of patients with cystic fibrosis-related diabetes, there is a dedicated chapter in the International Society of Pediatric and Adolescent Diabetes covering the diagnosis and treatment of patients with cystic fibrosis. This guidelines is updated 2024, but the content of the chapter is not changed, no updates in it. The diagnosis of patients according to oral glucose tolerance is defined according to American Diabetes Association criteria for diabetes diagnosis. And as you see here in the last two lines, we have two entities to diagnose. We have some patients with cystic fibrosis-related diabetes without fasting hyperglycemia, and it's diagnosed with postprandial hyperglycemia more than 200 milligrams per deciliter. And we have another entity with patients with cystic fibrosis related diabetes with fasting hyperglycemia, and it's sufficient to have fasting hyperglycemia more than or equal 126 without needing oral glucose tolerance. And there is a state, an indeterminate state. It has a very long-term implication for management of these patients, but it's not categorized as cystic fibrosis-related diabetes. As you see here in that figure, the highlighted red, it highlights the patient with impaired glucose tolerance. And as you see here, the impaired glucose tolerance can start very early in life since the neonatal period, but it has a peak incidence around the age of 10 years, reaching the peak of cystic fibrosis-related diabetes around the age of 18 to 24 years. For that, we have to screen for the patients with cystic fibrosis to search for the diabetes. The diagnostic symptoms are very subtle and may be asymptomatic, ranging from the classic symptom of unexplained polyuria or polydipsia, ranging to deterioration of the pulmonary function, failure to thrive, or arrested or delayed puberty, till we have no symptoms at all, so we have to screen for the diabetes. So the most important question, when to start screening? The most important age of screening at 10 years, but we can start screening earlier than that if we have risk factors like the steroid therapy, the parenteral nutrition. Some centers start at the age of 6 years. The interval of screening is annually, and how to screen the oral glucose tolerance is the standard screening method. Hemoglobin A1C have no rule at all for the diagnosis or the screening, as patients with cystic fibrosis usually have chronic inflammatory status, which lead to premature RBC destruction, which affect the levels of hemoglobin A1C. The random blood glucose and fasting levels are no importance for the diagnosis. We have the famous table to differentiate between the types of diabetes, and mainly the antibody-mediated immunity is the main difference between type 1 and cystic fibrosis-related diabetes. And we have some situation which does not necessitate to do oral glucose tolerance, as most of the pulmonologists encounter during the exacerbation of the disease with the use of intravenous antibiotic and systemic glucocorticoid. It's sufficient to have the cut-off diagnostic level of fasting plasma glucose or the 2-hour postprandial plasma glucose persistent 2 days after each other. And sometimes in patients with overnight enteral feedings, it's enough to have a mid meal or immediately after meal to have blood glucose level more than 200 on 2 separate days to diagnose fasting plasma glucose. And the question, is it always the patient with cystic fibrosis have cystic fibrosis related diabetes, or sometimes the patient suffer from type 1 diabetes as any autoimmune process? And actually, yes, it could be affected with type 1 diabetes, and there is some criteria to screen for the autoimmunity if the age of onset less than 10 years, if there is coexistence of autoimmune disease in the family, if the high intake of insulin or development of DKA at the onset, so go for antibodies to diagnose it. And the management of diabetes is the interplay of the diabetes management, the nutrition education, the monitoring, the insulin therapy, and the exercise. It's different in patients with cystic fibrosis-related diabetes, which complicates the management a little bit. They have a certain medical nutritional plan. They have a high caloric intake, high salts, and a high fat diet, which a little bit complicate the counting of the diet in patients with cystic fibrosis. Insulin therapy is the only modality. Usually we use different regimen with different methods of administration, and we start with medium dose of insulin, 0.5 to 0.8, And to keep in mind never to use oral hypoglycemic drugs. Some centers use oral hypoglycemic drugs, but it's actually not FDA approved till now and no enough evidence about it. There is a state of abnormal glucose tolerance, the pre-diabetes stage. There is a debate about to treat or not to treat, not evidence yet. And the era of diabetes technology, these patients, they deserve to have the continuous glucose monitoring and the pump therapy for introduction of insulin. And it's actually the continuous glucose monitoring is approved for patients with cystic fibrosis to monitor during the insulin therapy, but not for screening. And let's go to the other complications, cystic fibrosis bone disorder, which is the second most important endocrine complication. About 95% of patients with cystic fibrosis suffer from this disorder. We have a very complicated pathway ranging from the CFTR mutation, which affected the osteoclastic activity, malabsorption with subsequent vitamin D and vitamin K deficiency, and the hypogonadism, delayed puberty, and corticosteroid therapy, which all affected the bone disease. DEXA scan is the most important diagnostic modality, and we have guidelines for screening for the bone disorders. DEXA scan must be done if the patient age more than 18 years, but we can start earlier, starting from 8 years if we have some risk factor as it listed in that slide. If the RDL weight is less than 90%, if the pulmonary function is FEV1 is less than 50% of the predicted, if we have the late puberty history of fracture and glucocorticoid therapy more than 5 milligrams per deciliter daily for more than 90 days per year. And according to the Z score, we have intervals for screening if less than. If the Z score more than or equal -1, we have to do screening every 5 years. If between 1 and 2, every 4 years, and if less than -2, yearly. And to diagnose osteoporosis, we have a clinical diagnosis combining the DEXA scan criteria and the history of bone fractures. Osteoporosis, if to diagnose it, we have DEXA scans that score less or equal -2 with significant osteoporotic fracture in the form of vertebral compression fracture or more than 2 long bone fractures or low trauma of the long bones of the lower limbs. And we have a list of investigation to diagnose for secondary causes of bone disorder in patients with cystic fibrosis and how to treat this patient, maximizing nutrition supplementation, as Dr. Dalia mentioned, and regular exercise. And we have multiple anti-osteoporotic treatment therapy. The most important is the bisphosphonate, and the future direction is highly effective modulator therapy. The linear bone growth is affecting all the patients. Most of the patients, in spite of improvement of the nutritional plan, due to the same complicated factors, according to the patient registry, the linear growth percentile is less than 50th percentile. With the advancement and the improvement of the nutrition, the incidence of overweight and obesity is increasing nowadays among these patients, and management of these patients through optimizing their nutritional status, and there is a role for recombinant growth hormone according to the Cochrane systematic review. And it improved the standard deviation score of the patient 0.2 to 0.6. And there is another trial for other medication like appetite stimulator, but the future again to the CFTR modulator therapy. The late puberty is reported. Lastly, it was reported to delay 2 to 4 years, but with improvement of the treatment, the age of puberty improved markedly, and it matches with the normal siblings. A lot of risk factors complicating this cause of the delayed puberty, like malnutrition, chronic inflammation, low levels of leptin, and the delayed puberty have a very negative bad effect on these patients, raising the incidence of the suicidal attempt and low self-esteem. And lastly, the thyroid dysfunction is reported in that patient, but no gross evidence about the thyroid dysfunction in these patients. And lastly, this is our team. Thank you so much for
Thank you, Noha. And, I'd like to thank, I was just asking Professor how to pronounce Michigan. I always put a T, I don't know, but the practice, it's a Michigan, so, and she was telling me that we have the word mish is all cheese in Egypt. So she's telling me to do this. And I know we deferred the questions, but what I'd like to do is to have your active participation of just commenting on what do you do. You have all the experience, so maybe I'll ask about the DEXA and the growth hormone. Any experience with it? Is it routine in patients? Just a 1 minute comment. I don't know.
We follow the guidelines for DEXA. So we scan our patients over 18 and then the ones younger who meet those criteria that were listed there. So we follow those same guidelines for us.
Okay.
And I would say growth hormone is very patient dependent. We will refer our patients with poor growth to the endocrinologist and they'll discuss it with them. And it's really an individual patient family decision with the endocrinologist.
Perfect. Thank you. That's,
Chris,
yeah.
patients with osteopenia, is there any particular, do you take any precautions when you're doing physiotherapy? Would you be afraid to break a rib, for example?
It would depend on the level of osteopenia. I will be honest, we don't see that high level of osteopenia where I worry about it. In our population, in the pediatric population especially. So I don't have a lot of concerns with it. We do recommend that body weight activity to help combat that osteopenia and prevent any of those. It's also as we're getting better using steroids, things like that, as management has gotten better, we have less of those concerns as well. But again, if they're being actively monitored for osteoporosis, osteopenia, we'll look at that. Sorry.
I have a question, but I have a question.
We're only allowed to ask you.
Like,
If you
my
have an
son,
American passport from Michigan, you can be asked.
my son is a periodontist, so I'm wondering, do they have any dental help with all of this steroids, dysbiosis?
Families have asked, but we couldn't find any literature that indicated that they were a higher risk for dental caries than any other child who eats a lot of sugar, high calorie things. So it's been questioned. We don't have any research that says, yep, you're going to have an effect just because you have CF.
Since we all got excited, I'm married to a psychologist, so do you have any psychological support for them in the program specific?
We do. We have social workers and psychologists who work with our patients and families. We screen routinely for anxiety and depression, and that is a big issue within our program and an area that we're really working to continue to improve.
So we're back to the lectures again, but we promise you more questions in between. So it gives me a great honor to present.